Assalamu alaikum and good morning. Diabetes mellitus management would be our today's topic for discussion, and primary emphasis would be on type 2 diabetes and its management. We have to understand the various site of action of various agents used for the control of hyperglycemia. Hyperglycemia is contributed by many factors, starting from the pancreas, the central nervous system, the peripheral musculature, adipose tissues, kidneys, liver, and of course the gut. Uh, the, the pancreas may be producing less insulin or producing more glucagon, and of course sulfonylureas and glenides are the one the agents which are secretagogues, which leads on to increased excretion of insulin from the pancreas. When you come onto the gut, then this incretin effect we'll be talking about that, what it is, and then the agents like DPP4 inhibitors and the centrally acting this glucagon like peptide 1 receptor agonists, and similarly alpha glucosidase. These are the one which act primarily on the gut, where they can lead on to an increased release of incretin, or decreased degradation of incretin, or maybe mm, less absorption of glucose from the gut, and of course sometimes controlling the gut motility and increase the gut filling effect. Metformin and bile acid sequestrants, they are the one which primarily act on the liver with decreased gluconeogenesis. SGLT2 inhibitors are the drugs which lead on to more glucose loss through blockade of renal glucose absorption. And then there are agents like metformin, again acting on the adipose tissue, and reglitazones acting on the muscles with the increased uptake of glucose by the muscles. And then there are dopamine agonists which can lead on to say satiety and increased filling sensations through central mechanism. Something about the how strict we have to be with our patient to achieve a tight glycemic control. Primarily, we um, aim a target A1C level of around 6.5 to 7%. We have to be a bit lenient with their patients if there are the low risk, but we probably have to go for a tighter control if someone has a high risk of other cardiovascular disease factors. The target set also depends upon disease duration, your patient's life expectancy, other comorbidities, already present cardiovascular risk factors, patient's attitudes toward treatment, and of course resource, incomes, and supports available. Like from this example, like if someone who has a say long life expectancy, you probably would go for a tight glycemic control as compared to that someone who has just 4 or 5 years to live, or very short life expectancy because of his age or other comorbidities. You may not be going for a very strict and tight control. Someone who has no other cardiovascular disease factors, you may be a bit lenient about his control. But if there are multiple say risk factors, like he's having hypertension and along with that dyslipidemia or other risk factors, then you possibly have to go for a more tighter or strict control. Lifestyle modification is the main stay of our treatment, so we don't just jump on to straight away to medication, to insulin, to other things. The first thing that we have to probably emphasize on our patients is that they have to adopt a healthy lifestyle with an increase in their physical activity. The minimal physical activity that is recommended for say healthy living is at least 30 minutes of a walk daily for at least 5 days in a week, or maybe a total of 150 minutes per week of physical activity, where you uh, get an increase in heart rate of around 50 to 70% of your maximal heart rate recommended. Or you may think of 90 minutes per week of a vigorous aerobic exercises like going to gym or other heavy exercises. Before beginning or say suggesting to your patient that they have to be physically active or to start exercise, you probably have to assess few things. You have to assess them for presence of other cardiovascular disease risk factors. Someone with uncontrolled hypertension may not be very say fit subject for starting an exercise program there and then. Those who have autonomic neuropathy again may be incapacitated and may not be fit for a very rigorous physical program. Those who have proliferative retinopathy or are elderly or have previously physically inactive should not be started on a very aggressive physical activity program there and on. And same is goes for the those who had an episode of ketoacidosis or ketosis should are not very good candidate to start with physical activity from on an aggressive pattern. The second component of diabetes management is medical nutrition therapy. What to eat, what not to eat, and it preferably has to be designed by a dietitian. The amount and type of carbohydrate which should be uh, allowed to the patient should be selected. The agents with say high glycemic index or the agents or free sugars which are absorbed very rapidly and lead on to very rapid rise in blood glucose levels should be avoided, and patients should be provided with the diet charts mentioning the carbohydrate content of each food component and of course the its caloric values. 60 to 70% of calories should be say achieved from carbohydrates, 10 to 20% from proteins, around 7% from saturated fats. Say if you decrease your caloric intake by around 500 to 1000 calories per day, you can lose weight for about uh, 1 to 2 pounds per week or maybe a 1 kg per week. Now this is again very important in particularly uh, obese diabetic patients where obesity is a major factor in not achieving the glycemic control. Obesity, as we said, needs treatment on its own merits with drugs or surgery, and we'll be talking about briefly on this subject as well. Antioxidants used in routinely is not very well recommended. All these patients should be, as we said, mm, given a program of diabetes self-management education program, which should be delivered through a nurse or dietitian, and it should address not only the physic this dietary component, but some psychosocial issues associated or emotional issues, say issues associated with the diabetes, because many time patients who are given or told that they are diabetic, they take it as a sort of a very say stigma or and this considered that possibly something very bad has hit them, and they go into some time of a severe depressive illness or maybe a lot of anxiety being struck, say um, experienced by these individuals. This is although quality of slide is a bit say dim, but I will help you out that the glycemic management diabetes patient starts from this the first component being medical nutrition therapy, increase in physical activity, or targeting a weight which is ideal for that to their height, and if they are obese, there is some weight loss. So after patient is diagnosed diabetic, you start from the first component of education, nutrition therapy, increased physical activity and weight loss, and of course you target an A1C level of around 6.5 to 7%, and then you monitor it maybe after 3 to 6 months of initial act this program being started. If you achieve target A1C through this and target daily day-to-day blood sugar levels, it's fine. But if you do not achieve, what do you do? Then you have an option of this oral medications. The oral medication may be in the form of insulin secretagogues like sulfonylureas, in the form of biguanides like metformin, in the form of alpha glycosidase inhibitors like uh, acarbose, and then thiazolidine drugs which are TZDs, which like say glitazones or pioglitazone or rosiglitazone. Along with this, if you achieve control, that's okay. But if then you fail to achieve the control, then you can go on for combination of these drugs. So you combine these drugs, and then again you reassess that the target A1C is achieved or not, and if it is not achieved, starting from the nutrition therapy in the first step, single agent in the next step, combining these agents in the third step, and then possibly sometime even going not only two but multiple combinations. And then if still there is failure to achieve, then in addition to that you add insulin to your agents, and then again you assess whether this target A1C is achieved or not. So now we will talk about one by one that what do we do. So we start in the top with healthy eating, weight control, increase in physical activity, diabetes education, and we probably set a target of A1C, and if it is achieved, well and good. But if not, then you can start with monotherapy or a single safe medication, and the best medication we probably have to look for whether the drug is effective, does it have any potential risk of hypoglycemia, what is its effects on weight neutral, or it itself may not lead on to increase in weight. Are there any side effects? And most important in our part of the world, what are the what would the cost to your patient? Is it an expensive drug, or it's is it say affordable by the patients? So if you go on to the on this merit, the metformin single agent which stands out that it has high efficacy, low risk of hypoglycemia. It is weight neutral, or sometimes may lead on to some loss of weight. Sometimes there may be effects like GI intolerance or nausea, vomiting, fullness, or lactic acidosis. Rarely been observed, and it is of course quite inexpensive drug. So probably that should be the first drug to be introduced, right? So you after initial 3 months of assessment on say diet and weight control program alone, you add metformin. At 3 months you again reassess that whether this is working or not. But if does not work, then this is a time to go for dual therapy, that in addition to metformin you can add any of the agents, either a sulfonylurea or thiazolidinedione is the second step, or DPP4 inhibitor, or SGLT2 inhibitors, or GLP-1 receptor agonist, and sometime you may think of starting insulin very early on, provided there are, as we said, multiple say risk factors which you think that possibly can lead on to increased cardiovascular disease risk. This again mentions about for each of the agents that what are the risks, like its efficacy or its say potential for causing hypoglycemia or any weight loss or weight gain, and of course side effects. So you, for any of the agents or class of oral hypoglycemic you select, you have to keep in mind these factors again and again. Sometime, or maybe you roughly say take a period of another 3 months, and if with the dual therapy or two agents still the glycemic control is not achieved, then you can go for adding another agent to it, or maybe adding on to triple therapy. So if the first line was metformin and second line was if any one of these agents, you can add any combination of your choice, or keeping in mind your patient's profile and keeping in mind the side effect profile of each of these agents. Again, still if it is not on target, then probably have to go for thinking of adding on to further insulins or other agents to be done. A word about insulin. The type 1 patients, of course, are, say, we may call them insulin dependent. They require, since there is total insulin lack or insulin deficiency, so they require insulin for survival. But for the type 2 diabetes mellitus, it may be considered as, say, initial therapy in the beginning, or sometime it may be required for a better control during serious infections or surgeries, or in women with gestational diabetes mellitus, where oral agents except for metformin are not recommended, or they do have some say teratogenic risk. So in that case, the insulin may be considered for a temporary use, and sometime it may be continuously used in patients with even with type 2 diabetes mellitus. There is a UKPDS is a large trial conducted on type 2 diabetes mellitus in UK, and since 1994 onward, there has been multiple publications from this single study, and this is an ongoing type of a project on diabetic patients. So the Robert Turner was the author of this, the lead investigator for this trial. And once he was interviewed and he was asked that what is the major thing you learned about diabetes management, particularly type 2 diabetes, and his answer was that we do not start insulin therapy early enough nor use it aggressively enough. So this highlights that even in type 2 diabetes mellitus, when there is a treatment failure or failure to achieve the glycemic control or A1C levels, there is reluctance on part of both physician as well as patient to start insulin or to add insulin or to switch to insulin. And once it is even instituted and started, there is a lot of, it is not, say, pursued very aggressively enough that to achieve your glycemic control. Sometimes it is considered that as if insulin is possibly the last thing to be done in a patient with diabetes mellitus, and that's many a time your patient's perception is that he probably feels that he has gone on to a stage where nothing works and it's only the insulin probably would be required, and probably it's end of the story. And it is not so, and of course many a time patients prefer to use oral hypoglycemic agents. There is, say, sometimes fear of needles, sometimes it is considered cost effective, sometimes it is considered that insulin probably would require adopting a very strict lifestyle changes. So that's why at most of the time uh, either patients are reluctant to use it, and sometimes even the physicians are a bit hesitant to use it. This is the typical response. हो इंसुलिन नो 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 इंसुलिन नहीं हो कुछ और दे दें जो मर्जी कर लें पर इंसुलिन पे तो नहीं आना. Right, so we what we do, as we already described, we start with diet, we start with the exercise program, we add one oral epiglycemic agent, we add another agent, we add another agent, but still the target is not achieved, glycemic control is not optimal. But if you suggest insulin, there still is sometimes a lot of inertia on part of physician or on part of patient that they are reluctant to go to insulin. So endocrinologists, they view insulin as an early practical way to improve glycemic control, and oral agents are often ineffective or they lose their efficacy with time, with the passage of time, or sometime there is not enough insulin reserve left in the pancreas to be, say, extracted by oral agents. So there is a strong case for insulin as attractive treatment for type 2 diabetes mellitus. We know that type 2 mellitus diabetes mellitus is a state of insulin deficiency, which is either because of beta cell dysfunction or beta cell deficiency or insulin resistance. And it is characterized by gradual deterioration in the beta cell function, and there is definitely progressive deterioration in A1C with the passage of time. And natural history of type 2 diabetes mellitus is that at some stage there would be an oral agent failure. The Another lesson which were possibly learned from Wikipedia is that we are not good at diagnosing diabetes mellitus. Most of the patients, since they don't have any symptoms, so they probably are diagnosed 4 and 7 years down the lane after the diabetes has already hit them and had hit them badly and has already caused some target organ damage. Then we also have to understand that all type 2 diabetes is not strictly speaking type 2 diabetes mellitus. It's a heterogeneous disease, and there are reports of say type 2 diabetes, actually late onset diabetes, being not always an insulin say uh, resistance or in a different destruction state, but it can be autoimmune, late onset autoimmune diabetes of the adults. Like type 1 diabetes, we said, is an autoimmune destruction of the pancreatic islet cells, and usually starts in very say juvenile age group, but sometimes it may start uh, some individual at slightly later stage. And these patients are difficult to distinguish from true type 1 diabetics, or sometimes this diabetes has been labeled as diabetes 1.5. Type 2 diabetes of insulin resistance, type 1 diabetes of autoimmune insulin, and this comes in midway between these two states. There is a limit to the extent to which this A1C monotherapy, this we can be brought down by oral hypoglycemic agent particularly. So on an average, a single oral hypoglycemic agents can reduce A1C level to around 1 to 1.5%. So adding to may have a beneficial effect, not exactly doubling the effect, but at least having an additional say glycemic control achievement of around 0.5 to 1% of HbA1c lowering. But when you add drugs, you have to be careful about their side effects, their contraindications, and of course their costs as well. So as we said, the natural history of type 2 diabetes mellitus is oral agent failure, so you have to consider insulin at some stage. And the since the primary target of our management is reducing the overall cardiovascular disease risk of your patients. We have been talking about that diabetes is not something which is alone. It is associated with other say risk factors like hypertension, dyslipidemia, increased atherosclerosis. So uh, any treatment which is aimed at hyperglycemia should not be just looking at hyperglycemia. We have to look at that whatever agent we are using, what is its effect on the overall cardiovascular, say, risks. And by that criteria, we know that the oral agents are good at reducing the blood glucose level, but they are not as good for other benefits or other cardiovascular benefits which are offered by insulin. So the guidelines for optimal glucose control are getting down and down day by day. Initially, we thought that probably an A1C of 7.5 is good enough. Then we said it was to be low to around A1C level of 7. But nowadays, we targeted that the A1C level should be reduced to 6.5% or less for optimal control. The limitation of oral hypoglycemic agents that already mentioned is that at the most you can achieve A1C lowering of around 1 to 1.5 or maximum 2 with oral hypoglycemic agents. But this is unlimited if you are using insulin for control of diabetes. The insulin not only leads on to glycemic control but also reduces the glucolipotoxicity defects, and of course an excellent glycemic control is attained through this. We all know that in endocrine disorders, when there is deficiency of hormone, this hormone needs to be replaced. So type 1, definitely it is an absolute indication that the patient should be on insulin. And in type 2, of course, with time, there is, say, lack of release of insulin from the pancreas, or there is a lot of insulin resistance to the action of insulin. And despite high level of insulin circulating, you would be having poor glycemic control. And so that's why that the standard, as we do for other endocrinopathies, is when there is deficiency, replace that hormone or add that hormone, right? So primary target of is to achieve glycemic control. Insulin can be considered for type 2 diabetes mellitus. Insulin is not the treatment of last resort but treatment of best resort. We'll talking about a little bit of the other say anti-diabetic agents which are being used. So we start with glucagon like peptide 1 and the incretin effect. This is the incretin effect, that when you take food and when the food reaches the gut releases hormone which is called as glucagon-like peptide 1. Now, glucagon-like peptide 1 is say a hormone which has 3 sites of action. It gives a signal to the brain that enough has been eaten, and probably it would be called an element of satiety, and this leads on to say decreased or reduction in food intake. It acts onto the stomach, that it delays the gastric emptying, so food is held for some time in the stomach and does not reach the gut immediately for absorption. So this delayed gastric emptying is again say achieved through this GLP-1, leads on to uh, slower glucose absorption. Then this GLP-1 gives signals to pancreas, that it stimulates the insulin secretions, it stimulates the beta cell proliferation, it inhibits the beta cell apoptosis, and it inhibits the glucagon secretion. So decreased glucagon secretion and increasing secretion, of course, then aims at controlling the blood glucose level or glycemic control. Now we have to understand then one more thing, that this GLP-1 is a very short half-life. So it within a few say seconds to minutes of its release, there is an enzyme by the name of DPP4 which degrades into an inactive form. So we'll be talking about DPP4 inhibitors, which would be used as a therapeutic agents for management of diabetes. This is again the same, that there's the food into the stomach would lead on to release of GLP-1 from the gut, and this GLP-1, as we already narrated, would have its effects on the brain, on the stomach, and on the pancreas. So the net effect of this would be that increased glucose dependent insulin secretion, increased insulin synthesis, decreased glucagon synthesis secretion, and this would lead on to reduced hepatic glucose output. It promotes satiety and reduces appetite, it decreased gastric emptying, and decreased beta cell proliferation, decreased beta cell apoptosis. So this all would lead on to that it would achieve a better glycemic control. As we said, natal GLP-1 has a very short half-life of around 1.5 to 2.1 minutes. There are synthetic, say GLP-1 receptor agonist available. Liraglutide is one example. So this is injectable form. The dose is around 0.6 milligram once a day. You can maintain it up to 1.2 milligram and maximum 1.8 milligram once a day. And this large dose is basically recommended for possibly managing obesity. So subcutaneous injection once a day at any given time can be started. Then for incretin-based therapies, you can use GLP-1 receptor agonist, as we already described, or there is another way that you can probably, the endogenous incretin can be, say GLP-1 can be made to last longer. So we can have agents like DPP4 inhibitors, which can lead on to increased half-life of the endogenous incretin or GLP-1. So this is again an example of that. What happens that you take a meal, you have your say native GLP-1 released, and this is converted into, it's an active GLP-1, right? Now this active GLP-1 is inactivated to inactive form within 1.5 to 2 minutes. Now this is brought about by this DPP4 enzymes. If you inhibit this enzymes, so this would lead on to a decrease. I will again show on this that so this is active form of GLP-1 which is inactivated by DPP4, and this inactive form is not available, and this duration of action of active GLP is just 1 hour. But if you block these enzymes, blocking these enzymes, what do? You block this, so you increase the active GLP-1, right? Now various agents which are available, there's a sitagliptin and vildagliptin, saxagliptin, nagliptin, then these are all end by the name of gliptins, and you can start with the dose of 100 milligram for sitagliptin to 50 milligram for vildagliptin, 5 milligram of saxalina. These two are not available over here. You can combine them with metformin, and you can have various combinations available as well. And this options we have for this one, that you can have incretin therapy in the form of GLP-1 receptor agonist, Incretin-based, and then there is Liraglutide we already just mentioned, and then there are GLP, DPP4 inhibitors, DLP-1 enhancers. Exenatide is externally derived, say, GLP-1 agonist, and again it is used in the dose of around 5 microgram per day, twice a day, to 10 microgram twice a day. Again, this is injectable form. There is a prolonged release formulation also available, and sometime you can go for the subcutaneous injection once a week. There are preparations available of this Exenatide long acting, where you only inject. The benefit of these agents is that they not only they lead on to control in blood glucose level, but they also lead on to some degree of weight reduction. Myelin is another agent which is secreted from the beta cells of pancreas along with insulins, and its effect is that it leads on to decreased in glucagon secretion and thus decreased hepatic glucose output, and also delayed gastric emptying, and promotes satiety. So myelin is another agent which would be not available over here in Pakistan still, but uh, can be used in combination with metformin and other agents for achieving a good glycemic control. Pralumitinide is another synthetic analog of myelin, again not yet available. Talk of the town, or what we can say is in last decade the most say remarkable discovery or remarkable intervention in diabetes is development of this SGLT2 inhibitors. Now this SGLT2 is an say enzymes which is released from the proximal converted tubules. So when the most of the filtered glucose, when reaches on to from after filtration from the Bowman's capsule, reaches the proximal converted tubules, this SGLT2 enzyme leads on to almost 90% of it being reabsorbed, and only very few is reaching the distal nephron for say excretion in the urine. Now if we can block this enzyme SGLT2, it will lead on to this reabsorption of glucose being blocked, and most of it, instead of being reabsorbed into the circulation, would be lost in the urine, and this loss would lead on to say more glucose being lost in the urine, and similarly the blood glucose level would improve or would be reduced. These agents usually end in the name of this as DPP4 inhibitors are all ending in gliptins. These are in osins, flozins, all right. So dapagliflozin or empagliflozin, and there are certain other agents as well. So these are the one. So there is a comparative study of metformin and dapagliflozin, and look at this combination leading on to a more say robust control in the blood glucose levels. As we said, canagliflozin by the name of Invokana was approved by FDA for control of blood glucose in March 2013. Then 2014 we had dapagliflozin, and then empagliflozin. Both empa and dapagliflozin are available over here in Pakistan, and they are not only used as a single agent or a monotherapy, they are also available in combination with metformin. A word about metabolic surgery, that since we have already mentioned that majority of the type 2 diabetic are obese, and obesity is a state of insulin resistance, particularly what we call as abdominal obesity, or say more of a say intra-abdominal fat being increased. So if we can achieve weight control through metabolic surgery, or through say gastric say surgical procedures where you shorten the gut and reduce the absorptive surface, you can achieve better glycemic control and better say weight control as well. So the bariatric surgery is talk of the town now, that this metabolic surgery leads on to, and there are various forms available. You go for sleeve gastrectomies, you go for say bending across the stomach so that its pouch is reduced, and less of say food is say reaching or there, and this also leads on to say filling effect or tight effect, right? So there are benefits associated with this bariatric surgery, that at around 2 years, the randomized controlled trials have shown that there is definite improvement in not only weight but say control of diabetes mellitus as well. So the evidence shows that the bariatric or metabolic surgery has helped type 2 diabetic patients to achieve good glycemic control. There is improvement in type 2 diabetes over, and not only obesity and diabetes but other related cardiovascular comorbidities were improved. There is reduced medication use for diabetes mellitus and other cardiovascular disease morbidities in patients who underwent this bariatric surgery. It was more efficient than usual for prevention of type 2 diabetes mellitus in patients obesity at the age of 15. There reduces the risk of cardiovascular death and myocardial infarction and stroke, and this results in say morbidity and mortality rates were same for general procedures such as gallbladder surgery, hysterectomy. So it is not risky to undertake this surgery, and it is regarded as an acceptable treatment option for obese type 2 diabetic patients. So there is a consensus developing for bariatric surgery to be used as say mean of controlling the glycemic control and weight control. Now these are the certain say goal which we have to set in patients with type 2 diabetes mellitus, that A1C level of less than 7, preferably 6.5, with the mean plasma glucose level of around maximum 150 to 160, which translates into around 8.3 to 8.9 millimole per liter. We have to have a preprandial level of less than 130 and postprandial level of less than 180. But as we already mentioned in the beginning, that tighter control of around 6 to 6.5 would be better for younger and healthier individuals, but slightly loose target in range of around 7.5 to 8 should be aimed in elderly individuals, those with comorbidities, or who have risk of hypoglycemia. And of course, we don't want our patient to have hypoglycemia. Thank you very much for your patient listening. We'll be talking about the diabetic complications one by one in the next two lectures, and then we'll be starting off with, say, other endocrine topics.